The ANA test, the anti-nuclear antibody test, that's the subject of today's video. And it's an investigation that rheumatologists have something of a love-hate relationship with. We do like doing this test. It can be very useful in certain types of immune conditions, particularly a branch of rheumatology called connective tissue disease. We also hate this test because it's frequently requested, often without clear justification, and then a rheumatologist is requested to interpret this, sometimes with a patient who's become quite anxious, worried they have a connective tissue disease, when actually none of the symptoms match. Now, I like to call this my check engine light, and this is a simple run through to help you understand a bit about the ANA test. So if you are driving a car and your engine light comes on, that is a potential cause for alarm. But you don't know that it's the engine that's the problem. Maybe there's an electronic issue. Maybe the light bulb is on the brink, but you're probably going to take it to a garage fairly soon. I was a bit worried that maybe with electric cars, we might not see check engine lights anymore, but I've seen in some electric cars, they still use the lights. So that's reassuring for this video, even though there's obviously no engine there. When you go to the garage, the first thing you're going to ask for is not to have the engine removed and replaced. You're going to ask for a diagnostic workup. Have a listen to the engine, plug in the diagnostic box, work out what's going on. And the same is true for the ANA. So what exactly is the ANA? Well, antibodies are produced by one of the types of the immune system. So we have our innate system, that's what we're born with and is there ready from birth. Our adaptive system is our lymphocytes, T and B cells, and the B cells produce antibodies to help us clear away infection. The nucleus is a component of cells and it's supposed to stay inside the cell. Inside the nucleus is all the genetic material that we need to function, to produce proteins that are necessary for the cell, but also to reproduce the cell if it's a cell that can replicate. That nucleus can sometimes be released from the cell, usually from cell death. So a severe infection that burst the cell, perhaps it's an infection where the immune system said this must be destroyed. Maybe you have an autoimmune disorder that's causing an attack on the cells directly. The more of these nuclei that are released, the more the immune system has to get rid of them somehow, and you may develop antibodies as part of that clearance response. So if you're looking at doing an ANA test, what do you do? Well, you take a blood sample. There's a little piece of gel at the bottom. The blood is spun through a centrifuge, leaving your cells and your serum separated. You take that serum, put it on some target nuclei, wash off the excess, pop on some extra chemicals that will bind the antibody and also attach to it a fluorescent molecule, and then shine that under a stimulating light, and the fluorescent molecule that's now bound to the protein that's bound to the nucleus fluoresces. So you get a positive fluorescence. Then you can dilute that down. And the more dilutions, the more strongly positive the ANA is. So the check engine light is a little bit more sophisticated. It's a bit like having an engine light that is very dimly on. You can maybe see it at night time, through to one that's burning really brightly. The stronger the ANA doesn't mean the worse the disease. It just means the more likely it is to be positive. Because many people have a low amount of nuclear antibodies. So if you dilute it, for example, 40 times, or so-called 1 in 40 dilution, that's pretty common. Maybe 10%, maybe even more of the population have that. But it's much less common to have a dilution of more than 2,000, for example. Okay, so when is it helpful? Well, a whole range of immune conditions can have a positive ANA, but especially we think of things like lupus. So if you are ANA negative, that makes lupus a lot less likely. Sjogren's, Scleroderma, and muscle inflammatory disorders are other areas where the ANA test can be really helpful. It's not only how brightly it burns, but also we can do a little bit more investigation from the ANA, so it has a few more tricks to give. Once you've discovered that the ANA is positive and you've worked out a dilution, you can then look at these nuclei under a microscope, and where these antibodies are binding, or the pattern of how they bind across the nuclei, can be indicative of what's more likely to be the underlying cause. Again, there isn't a fixed pattern. It doesn't mean that because you don't have the right pattern of ANA, it can't be this condition, or because you have this pattern, it must be this condition. But we put this all together like pieces of a jigsaw puzzle to try and build the best picture of disease. So if the antibodies are spread across the nucleus in a homogeneous pattern, that might be more likely to be lupus. If it's centered on the particular structure called the nucleola, the structural nucleoli, that could be in things like systemic sclerosis or myositis. If it's focused on little dots around the nucleus in areas called the centromere, that could be more associated with systemic sclerosis. And things like speckled can be fine or coarse speckles, but maybe slightly less specific to a disease pattern. So great, we found that ANA is useful and it diagnoses lupus. No, that's not what I've said. ANA is helpful and can help suggest lupus. Unfortunately, your ANA can be produced because of infections. They can be related to other non-rheumatological diseases, so autoimmune diseases of the thyroid, autoimmune diseases of the bowel like Crohn's disease and ulcerative colitis, and autoimmune complaints in the liver like autoimmune hepatitis. It might be following a nasty infection, and to be honest, in some cases, we just don't know the significance. So how do we put this all together? Well, the most important thing, as in most clinical medicine, is the story of your symptoms. We call that the history, and the examination findings. If it sounds like you've got a connective tissue disease and the ANA is positive, suddenly we're building a pattern that fits. If someone has done an ANA test because they wanted to screen for autoimmune disease, you have no features of a connective tissue disease, and all your other tests are normal, this is unlikely to be helpful, especially if it's low level or non-specific pattern of staining. So what's the take home? Just like with the check engine light, go into a specialist garage to look at your engine is going to be sensible. If you have a positive ANA, you need to get this checked out by a specialist rheumatologist who can give you better guidance on what it means, how significant it is. And just like the garage, we have our own fault code checker, things like the extractable nuclear antibody, ENA, and other antibodies like double-stranded DNA antibodies and Hall tests that can be helpful in digging a little bit deeper into a positive ANA. So I hope you found the video helpful. I hope this has helped explain this ANA test that you often hear about in rheumatology. I'd love to hear your comments or any questions you have. And as always, if you find these videos helpful, a like, a comment, a share, or a subscribe can help the visibility so other patients can see these videos as well. Thank you.